Hi, and welcome to episode 2 of our web series, COVID Conversations with Scientists, recorded on December 4th, 2020. This is our question and answer episode on long-term COVID, and the same panel that we had in our first episode is we'll have again in this episode. In this episode, in the previous episode, we discussed long-term COVID from the point of view of two people that experienced symptoms, have been infected and then experienced symptoms. They are Dr. Fran Broyles, who's the medical director of diabetes and endocrinology nutrition at Swedish Health System, and Sarah Suwilalat, a co-owner of the Refinery Salon at Edmonds, Washington. In addition, we have on the panel Dr. Brenna Hill, a viral immunologist and also a vaccinologist working at the Frederick National Laboratories in Frederick, Maryland. Dr. Angela Rasmussen, a virologist with a position at the Georgetown Center for Global Health, Science and Security. Dr. Warren Dinges, a physician scientist, board certified in infectious disease and internal medicine in a private practice at downtown Seattle Infectious Disease Clinic. I am Don Sedora, a viral immunologist working at the University of Washington, Seattle Children's Research Institute. So we'll just get started with the questions. First question, this is for Sarah and Fran. Since our last episode, when you introduced yourselves and your symptoms that you were having, how are you feeling? How has the last 2 weeks been? Let's start with you, Fran.
Yeah, so since I have, unlike Sarah, I have episodic sort of symptomatology, so I have relapses. I feel good in between those relapses or fairly back to normal. I'd say 80% baseline. So I am in between relapses and I've had a pretty good time frame in terms of symptoms. Again, my sort of 80% is just not, my energy's not completely back. My exercise endurance is not where it was before COVID, but definitely better than relapses.
Great. Sarah?
Yeah, I'm probably on the other side of that, Fran. This past 2 weeks has been rough for me. And I think I did go back to my doctors with my little notepad of Warren's questions and asked, just kind of, and Dawn had sent me a YouTube prior just about different supplements and things that you can take, because for me it's the fatigue. It's 24/7 for me, and because of the 25% capacity with our state right now, I shortened my days of working, but I extended my hours, so I'm working like 2 9-hour days, and we're usually on a 6-hour schedule. And last Monday and Tuesday, I almost didn't make it. Like, I literally had to go sit in my office and like put my head down and regroup, and I think now that I'm a lot more aware of my symptoms, it becomes like more like a head game too, where I have to like hype myself up, stay super hydrated. So on one hand, I'm taking the best care of myself I think I ever have, but on the second hand, it's frustrating because there's no results for me. So it's just the fatigue and then the body aches. And I know we were talking before we went live here about all the Zoom calls that we're all stuck in every day. I'm also not used to sitting behind a computer, so I kind of attest it to like sitting down a lot. But I did talk to my primary, and they said that they want to check liver stuff for me. I don't know what that means. You guys can fill me in on that. And I am taking supplements like the vitamin D, vitamin C. I'm looking at my list, B3, zinc, all that stuff. But I just started heavily doing that this week, so I can't really report if I think it's helping or not. Yeah, so Dawn texted me the day and asked how I was doing. I'm like, not a good week for me. So yeah.
Sorry. Yeah.
Yeah, sorry to hear that. But it's I guess we get both sides of the coin. You can have good weeks and bad weeks at this point, right?
Yeah.
So we're going to do questions, and so we're going to start with some questions from YouTube that people posted, and then we're going to go to some other questions that just came in from different sources, and we'll go to the panel, and I might call out some names if I think somebody's going to be a good person to respond. First question from Kate Coffey, posted on YouTube. If your immune system gets reprogrammed from COVID, do you think it would be possible for us to reprogram it back? And I think I want to go to Fran maybe for a start on this one.
Yeah, I think what's interesting is, there's a lot of data on fasting in the world of medicine right now. There's fasting for longevity, there's fasting for treating things like diabetes and obesity. But there is some data that's accumulating about fasting having an anti-inflammatory effect. And that is, I think, still a very new area of medicine. And I think the hard part about fasting is it's very tough to know how to do it if indeed you're trying to get an anti-inflammatory effect. So do you just fast 2 days a week? Do you fast 3 days in a row? Do you fast, in a certain pattern? And then, by the way, how do you refeed after a fast? So I think the data on fasting is fascinating, and I'd be interested in Angie's thoughts about this, given that she talked about the reprogramming issue. But suffice it to say, people who have there have been people who have autoimmune disorders whose inflammatory markers have completely normalized with fasting, and so it's an interesting and promising arena. I haven't tried it yet.
Angie?
I will just say that I agree with you that there's really not a lot known about the effect of fasting on long-term inflammatory sort of homeostasis. But I remember every time I've seen a talk on sirtuins, which are these master regulators that if you cause mice to fast or flies to fast, you feed them a reduced calorie diet, their longevity is incredibly extended. And it's because these sirtuins, which are the genes that underlie this effect, are really these master regulators of all kinds of different processes, including genome replication, cell division, telomeres, which is, and your epigenetic system, your metabolism. So it makes sense that fasting might also have an effect on these types of master regulators that will then have an effect on your inflammatory system. And the relationship between your inflammatory system and your metabolism is pretty well known. What's not well known is the specifics of that. So we know what all the big players are, but we don't really know about how to fine tune a lot of those things. So I'm very interested to see the results of any clinical trials that might result from experimenting with fasting and seeing how it affects long-term inflammatory outcomes. But I don't think there's a lot known right now about how that might impact this.
Agreed.
I think we could say that we don't know the answer, but this is something that might help, right?
Yeah, I think it's also, I think it's important to consider that implies, number one, that our immune system has one program, and that our immune system in our foot and our immune system in our liver are different things. Those are different cells, and they may not be reading the same gene instructions that we could loosely call a program. I have a patient who has one finger, and his finger always gets inflamed, and he has an eczema there that's severe, but it's only in that one finger and not on other fingers on the same hand for the most part, and not on the other hand. It's like, how would you begin approaching his systemic immune response for that one finger? So we give him a steroid he puts on his finger and treat that there. That doesn't necessarily mean we could put a steroid over his whole body and suddenly get a good total body response. So, I mean, we have to be cautious.
So, so we're going to go from a question that we don't know a good answer to a question that we do have an answer to. Also was posted on one of our sites. What are the options open to people that have long-term COVID? And for this one, and this is with regard to social media, it's the way we're interpreting it. And I guess you're going to comment on another thing. Brenna is going to actually answer this one, and I know she has a couple slides, so I'll let me share the screen. Hold on one second. And okay, you should have it.
Okay. Right. So basically, because of that question, I did some research on the internet just to see what is available to anybody who is dealing with long-term effects from having COVID-19. So there's a particular website called C19recoveryawareness.com. It was basically a site that kind of collates a lot of the resources that may be available and may be helpful to people who are dealing with long-term COVID. It basically lists on-site recovery centers, both in the United States and internationally, that are available to people. It also lists a whole bunch of online resources for information to help with your recovery and wellness, both internationally as well as in the US. They also had a lot of online support resources listed for anybody that wanted to check them out, especially if you spend a lot of time on Facebook or Twitter. They had sites for Reddit and Slack. They also had a webpage listed of all the completed clinical studies that have been done to date so far, both in the United States as well as internationally, and also any study that's currently enrolling people who are dealing with long-term COVID symptoms and things like that in the United States and internationally if you wanted to take a part. So just to give you an idea, I actually clicked on some of these links just to make sure that they were valid actual COVID-19 support groups. And as you can see, there's one, I just took a picture of the screenshot. I didn't actually go inside the group because a lot of these are private groups. But there's a COVID support group. There's one that's called Long Haul COVID Fighters Round 2. And there's also one that's called Long COVID Support Groups. These are Facebook groups that you can go, and it's just people who are dealing with this, and they can share their own experiences, share their resources, things like that. Twitter had a whole bunch of different hashtags that you could follow and see what people are experiencing. And they've listed not only for what you see in the United States, but all over the world. You've got French and Spanish, Finnish, Italian, German, and Japanese. So it depends on where you are in the world and what you're dealing with as to which one might be more appropriate for you. But there was a page from the Bassett Health Group that wanted to kind of give tips for people who are dealing with long-term COVID. One of them was to stay on top of your symptoms, basically knowing the type of symptoms you're dealing with, the frequency, the severity, and to be able to make sure that you let your doctors know, especially if things get worse. There's a whole bunch of websites and apps that are available to help you with tracking your symptoms, either identifying what they are or actually tracking and making a diary of them. There's stuff most of them are COVID symptoms. There's one that's called a People With, and it's not specifically for COVID, it's for any disease, but it's something that you can do personally for yourself, where you can actually track your own symptoms and keep a diary, and it will help you create reports and things like that, so that when you do talk to your doctor, you can actually give them a report of everything that you've been doing, so you don't have to try to remember everything. You can actually record it daily. Basically, they say, especially if you have any underlying condition like diabetes or a heart disease type of condition, to try to best manage that as best as you can while you're trying to recover from COVID. Also, be good to your body, especially like what Sarah was saying, is she's probably taking much better care of herself than she ever has. Best to get as much rest as possible. Try to do their best to eat as healthy as possible, and if possible, to reduce your stress. And the biggest thing that this site, as well as many other ones that I looked up, was ease yourself back into activity. You don't want to jump back into your full life activities right away. Keeping your spirits up, basically, support networks, your friends, your family, be sure to let people know that you are dealing with something, and, for them to have patience and, and be there for you, as well as setting doable goals, because as you're going through this, especially if you're either episodic or you have, like Sarah was saying, she has a bad week this week, or like with Fran, where, it's episodic, so that something might come, basically just to listen to your body, especially when things start to go wrong. Go at your own pace. And then, of course, like I said, I did Google searches just to see what was available for everybody. And there's a lot of community resources that are listed, especially if you say COVID-19 resources and whatever area you're living in. And there's all sorts of pages and all sorts of resources that are listed. So be sure to tap into every single one of those that you can. And that's what I've got there.
Great. That was fantastic. I think that will hopefully help some people out there looking for resources. It's maybe too many choices. But I guess they can go through and look and see what fits their lifestyle and symptoms, and just questions best. Do you guys have any comments, Fran or Sarah, about Anything that
It's a great list. I love the idea of tracking symptoms because I think you just kind of plow through your life and you don't really track what's happening with you. That's certainly true of me because it's episodic. So I like that issue of kind of keeping a diary and being able to do that in a way that's, helpful when you go in to see someone, when you go see your physician.
I think for me, like that little slideshow is probably the most informational stuff I've had so far. So I took lots of notes, Brenna, and I'm probably going to ask Dawn to send me those slides. But
Brenna,
shared cheating is
you guys can share
whatever.
your
I can certainly share those with you.
Yeah, I think I know when Fran said that she'd been tracking her and her husband's symptoms last time, that made sense to me, and I haven't been doing it. I'm still a little unclear on the difference between, she says that she has relapses. So you're saying you can go like a couple days to a week, Fran, without any symptoms, and then you'll kind of relapse back into like fatigue or headache.
Yeah, I mean, I'm having these about once every 4 to 5 weeks, and they've lasted about 72 hours on average, although the last one was 5 days. So
is it normal that like I feel like mine are 24/7? Are you guys
Yeah.
seeing that? Okay.
I mean, yeah, it's and I get a prodrome of typically terrible body aches, exhaustion, sometimes a sore throat, headache, and then just wiped.
Yeah.
So what you're feeling kind of chronically
Yeah.
is what I dip into.
Throat, because last night I had a sore throat, so I'm like FaceTiming with my mom because I still act like I'm 10 when I talk to my mom, and I'm like making her look at my tonsils. I'm like, "Do you see anything?" And she's like, "I was like, I'm going to bed." It was like 8:00, She's like, "Oh my gosh," because it's always something. But yeah, the sore throat, that was a first. So then, of course, right now, anybody has any kind of symptom, and we're automatically like doing the worst thing that we could do as non-doctors and Googling. Getting on WebMD or whatever.
I guess
Fran, I was gonna say, Fran, with your episodes, have you noticed them changing? Like, you said it's about every 4 or 5 weeks. Did they start off more frequent and then they're getting longer that maybe you're starting to resolve, or they've been
Yeah, I
pretty
mean, I was very hopeful with that because this most recent episode was closer probably to a 6-week interval, although this one was worse. And it was the first time that I really had severe nausea again. So I not quite sure how I feel about it. I mean, I was thinking, it's getting further apart, but then it was an episode that lasted longer. And I do think that my episodes in part are potentially precipitated by fatigue. By work. And, Sarah, I think that's an interesting thing for you to track as well, is you're doing these 9-hour days. Is that driving worse symptoms following those days? Because, that would make sense, just as wearing on your system.
Yeah.
And are you eating properly and sleeping properly on those days and all those things, right? You don't, right?
I can only do so much. But yeah, the eating thing, and I'll ask you guys that too, because in the research that I have been doing, they were saying to kind of treat it as kind of like the inflammatory diet, right? But I've kind of gotten some mixed information. Like some people are saying like, no avocado, don't microwave your food. I mean, I know ideally eating the cleanest is the best, but what is your guys' advice as far as like eating, a balanced diet during this time, staying away from any inflammation based foods, or,
I mean, the anti-inflammatory diet in general is indeed no processed sugars and carbohydrates. Basically fresh vegetables and fruits. Warren, I don't know if you have any thoughts or input on this, but the anti-inflammatory diet that is taught by rheumatologists, people who treat things like lupus and rheumatoid arthritis, there are certain food groups that are felt to be inflammatory, even in the vegetable arena. So I think dietitians are the ones who are really trained in this, but it is really trying to eat non-processed foods and staying well hydrated. And that's the way that I think about it.
Yeah.
Warren, any comments on any of that?
No, I mean, I think I find I'm concerned about any strong recommendations about diet. Any diet recommendations just don't have a lot of foundation and good data. It doesn't mean that there won't be an effect and one person won't see an effect It's that fundamentally eat a well-balanced diet, fresh fruits and vegetables, avoid processed things, and then picking one particular vegetable or fruit over others just doesn't have a lot of data behind it. I mean, I think eat all the avocados you want. If that means you're not eating, sugar in a box with a label, yes, eat avocados. And I don't really hold. I haven't seen much data to support any recommendations outside of a well-balanced Mediterranean diet. And even if you pick things like the Atkins diet, which is going away from carbohydrates completely, it's fine. I mean, they're comparatives of different diets for weight loss or whichever. They're not great right now. And we don't have good data to make any recommendations about an immune effect of diets. So, I mean,
I agree.
Yeah.
Most of the studies on diets are 12-week studies,
Yeah.
and they're patients who are not locked into a clinical research center. So you basically tell them how to eat and hope they do it, and then try to follow the response. So I do think it's hard to know about dietary interventions, but in general, processed foods are a bad thing.
Yes.
Sorry, do not eat sugar out of a box. You heard that from
Don't eat Lucky Charms out of a box.
Try not to drink cane
I didn't say the brand.
All right, we're going to move on to our next question. This comes from Alex N. It was posted on YouTube. She started off by giving us a compliment. I appreciate the talk about how patients can advocate for themselves for something new like this. This is from our first episode. And the question was, thanks for the interesting discussion. I'm curious if there's been any correlation between severity of the initial illness and probability of relapses or long COVID. My aunt and uncle both got COVID, and the one who was on a respirator has fully recovered, but the other, who was much less affected initially, is still having symptoms. So comments on whether the severity of the initial acute illness influences whether or not you get long COVID.
I think that the data is really unclear, but there are certainly people who've had mild or moderate COVID, people who were not hospitalized, who have reported having long COVID. I think that there's multiple manifestations of long COVID as well. So there's relapsing, which is Fran has described. There's fatigue that's really persistent, like Sarah has described. Others have reported things like reduced lung function, and that was actually also reported from people who have recovered from SARS coronavirus classic that has persisted, up until now. They've had reduced lung function for 17 years. So there's a lot of different forms of long COVID, and I think that they can occur with acute disease that's of all different severities around the severity spectrum. And I should add that MECFS, or chronic fatigue syndrome, is thought to potentially be, at least in some cases, associated with a viral infection or some type of infection, but often people can't really point to a specific time that they were very sick. So it's entirely possible that some of these really complex chronic diseases that are associated with chronic inflammation or chronic fatigue are the result of a very mild or subclinical infection.
Yeah, I would say as a clinician who sees chronic fatigue, I would agree with that, Angie. I think a lot of people don't pinpoint a severe viral infection that resulted in the development of the symptoms. And, I think it's interesting, as scientists to realize that the immune system has some very potentially negative effects. So, our response to insults from the outside can then lead to chronic stuff that's, messing with our own system that persists. So the immune system is a double-edged sword. And that's, in part what they're trying to manage with COVID when they're doing Decadron. We're trying to tamp down certain aspects of the immune system, but not enough so that you actually, the virus goes wild. So it's definitely not firing off your immune system if you don't have to is a good thing.
I think it's also interesting to just think about infectious mononucleosis by Epstein-Barr virus. And that's a disease for which a large percentage of people afterwards have long symptoms for a good duration afterwards. And you pair that to other viral diseases, even Ebola recently. I saw some paper that had a couple of papers that had longer term effects, months to years afterwards. So there's other ones, chikungunya, other viral infections, and even chemotherapy. Patients who are undergoing chemotherapy have chronic fatigue afterwards. So sure, it's there, it's real. The question is, how do you manage it?
Yeah. Well, good
I'd actually
question.
be curious to hear, Warren, from both you and Dawn, studying HIV. I mean, that in some ways is a disease of chronic immune dysregulation. I don't know if you have any thoughts on how that relates to this question, or if you think it does at all, but that is something somebody used to work on hepatitis C virus, which is also in a different way a disease of long-term inflammation and aberrant inflammation. It's something I've started thinking about a lot.
Yeah, I mean, for HIV, initially they thought everything was tied into this loss of just this one particular type of immune cell, the CD4 T cell. And it wasn't until the early 2000s and mid 2000s that we figured out, to the knots, whatever, that, 2000 to 2010, that we figured out that it was a lot of the symptoms were actually tied to inflammation. And but there you have this virus that's also there, that's replicating. It's not this kind of acute infection that goes away, right? It's this chronic. So we attributed a lot of it to the virus itself, although there's other data that says maybe it's not all about the presence of this virus. So it could definitely all be similar for all these different viruses. Warren, did you have a comment on any of that?
Yeah, I would say certainly. I mean, fatigue, a diagnosis of fatigue was included in some of the diagnostic criteria of early AIDS. And then once we had suppressive antiretroviral therapy, which is the medicines that suppress the viral replication, then much of that has gone away. That doesn't mean that people with chronic symptoms with HIV are completely resolved and they don't exist. But certainly, like in HIV care, we treat the viral load and we measure that. When the viral load has gone down, most people return to a vastly normal life. You flip that around, hepatitis C, people walk around with decades for this virus. It's at a very high level in their blood. But I've seen now that we recently, in the last 5 years, have been curing so many people with hepatitis C. You see the flip of that, which is these people have been walking around and they suddenly wake up afterwards and they're like, wow, I have much more energy than I had after it's been cured. And I've also seen people put on a lot of weight. I mean, 10 to 20 pounds in the 6 months after you cure hepatitis C is probably normative, because the liver is not having to fight this virus anymore. So, yeah, I mean, there's a two-edged sword again of the metabolism of a virus replicating and how that affects the human that's producing the virus.
I'm going to go on to the next question. This one was brought to us in a way that I do not know how, but it was dropped off in our laps. So if the vaccine activates, we got all this great news about these vaccines that where two of which had excellent results, and there's a third that had good results. So it's really looking promising, but there's questions with regard to long-term COVID, and this is the question. If the vaccine activates the immune system, will long haulers have a worse reaction? And is there any reason to think the vaccine will improve long haulers?
So we don't know. That's really the answer. I mean, vaccines, generally we think that most of the COVID vaccines are working by generating what are called neutralizing antibodies. These are antibodies that bind the virus in a place on the surface of the virus particle that prevents it from being able to bind its receptor and enter cells and infect them. But we don't really know. The immune system is a lot more complicated than just neutralizing antibodies. So it's entirely possible that vaccines could have off-target effects that do enhance some of the more negative aspects of long COVID. We've given these vaccines to 30,000, 40,000 participants in these phase 3 clinical trials. That's actually a really small number of people compared to the entire population. So some of these questions we won't really be able to answer until people start being vaccinated in large numbers.
Yeah,
Yeah.
I would agree fully. We just don't know, because if you take chickenpox as the example, everyone used to get that. Then we now have a vaccine for it, and younger people have all been vaccinated. Well, people then previously have gotten shingles, which is a reactivation of this virus that has a bad symptom of pain and a rash with it. Well, we have a shingles vaccine that stimulates the immune response, and so, but you still have that virus in your body, and you walk around with it your entire life. So we're giving a vaccine that in essence is a therapeutic vaccine in that case to alter the immune response to prevent the pain from shingles later in life. That's the purpose of the vaccine. So that's in that case, but most of our vaccines are preventive. They keep you from getting infected with something. And I worked in an HIV therapeutic vaccine study where it took people who had HIV and see if you could inject them with this vaccine and get their viral loads to go down. And they had great immune responses that you could measure in terms of antibodies or CD8 T cells, but they had no change in their viral load. And so we just don't know. And humans are complex. Our immune system is complex. And, that's why they do the clinical studies. And these now phase 3 studies are larger, thousands of people, and see, do you have a problem?
But just to clarify, I don't know that most of the vaccines prevent people from getting infected. I think they mostly prevent people from getting sick, right?
Yeah, so we don't really know that. The primary endpoint of all the clinical trials so far has been protection against symptomatic COVID-19. The biggest open question, in my opinion, about all of the vaccines is, can they actually prevent infection, or at least can they reduce viral loads to the point where people are not able to transmit it to others?
Yeah, I was thinking relative to hepatitis A vaccine, which our best vaccine, which that actually prevents infection.
Yeah,
As opposed to like our worst vaccine is probably approved one is anthrax vaccine, which you have to get multiple doses, and every quarter you have to get another dose for. And
yeah.
it's like, so that's sort of the spectrum of good to not so good.
But the idea that a vaccine stops disease is a common thing. It's very many of them. That is what they do. That is their goal, not to actually prevent the infection, but to prevent the symptoms.
That's right. So sterilizing immunity, I think, is really nice when it happens, but the vast majority of vaccines don't actually achieve that in most people.
And I think Angie's point that we don't know that antibodies or T cells we have no idea what is the component of the human immune system that alters both infection risk as well as that alters disease symptomatic presentation, like being intubated, being sick, having to go to the hospital, having long haul symptoms. We don't understand any of that at this point.
Yeah. Okay, we got one more question. Fran, you get the last word on this one though.
Yeah, I just was putting this out to Angie, Brenna, and Warren about, our knowledge about viruses in general, certainly the flu and the ability to change rapidly. Obviously the Wuhan virus was presumptively morphed rapidly in Italy and became more contagious. At least that's the theory. So I'm presuming that we're going to need a vaccine every year or every couple of years. Or does anybody have any speculation on that? I know we don't know. But does anybody have any thoughts?
I have strong opinions. They're based on data. So I think what you're referring to might be the D614G mutation in the spike protein, which was initially associated with, and now it is the dominant variant that's circulating in Europe and North America. It's still not clear to me that this is the result of anything besides what are called founder effects, meaning that this was introduced multiple times in that area, and so it became the dominant form, not because it actually conferred any type of advantage. So they have now done some studies to show that it does provide a slight fitness advantage in cell culture, as well as in animal models. So it causes more replication in the upper respiratory tract of hamsters that have been experimentally infected. And in one paper, it caused hamsters to get infected more quickly in an aerosol transmission model. But I should add that all the control hamsters also did get infected. So does it matter that they're getting infected at day 2 versus day 4 post-exposure when they're all getting infected anyways? It's hard to say if that's something that actually makes a difference in the real world. And I would say that we don't really know if we're going to need another vaccine in the next year. It's certainly possible with any RNA virus. They do have a higher mutation rate, but unlike influenza, this virus cannot reassort. There are not other viruses circulating around that we know that cause severe disease, so it couldn't recombine with that necessarily. And coronaviruses actually do have partial proofreading capability, so they can correct some mutations. So it actually has a lower mutation rate than like influenza virus or other RNA viruses like Ebola. So it's something we need to keep an eye on. We need to conduct robust surveillance, but it's not a guarantee that we'll need a new vaccine in a year because the virus has changed. Whether or not we need a new vaccine or at least a booster shot in a year because the vaccine is not that durable is another question.
There are virus vaccines that have been used for decades requiring no change. So it really depends on the structure of the virus genome, how well it replicates, and does it have the looseness of that replication and the impact of those changes on disease. Like we know for HIV, it varies enormously, even a single patient in a single day who has chronic disease. So, and flu, as Angie was saying about reassortment, it's different when you have a farmer working around pigs and there's some ducks that he's got and he gets the flu and then can spread that. That's how you get this reassortment of flu being new each year and why we have to adjust for that. That's not the case with this virus. So it is plausible in my mind that we may not need annual vaccines. I would be surprised if that's the case.
I agree with that.
That's good news.
Yes.
On that, we'll have to end that question to go on to our final question, final round. And the final question is this: is it too late to think about monoclonal antibody treatment in long haulers?
Maybe. We don't know, but it's very unlikely that long haulers are actually still infected. There have been a couple cases of reinfection that have been reported. We don't to this time know how common that is, but the vast majority of people who've tested positive after they've completely recovered from their symptoms have not been associated with new transmission clusters, and they haven't been able to culture viable infectious virus from those people. So it's really likely. It's possible, of course, that people may have virus hiding out in an immunologically privileged site. We saw that with Ebola, for example, in which Ebola was sexually transmitted because it was sort of hiding in the testes of people who'd recovered from Ebola. We don't have any indication that that's the case for this particular virus, however. So I think that in many cases, I mean, my personal hypothesis, unless proven otherwise, is that people who have long COVID are really suffering from persistent symptoms that are continuing after the virus has been cleared and they're no longer infected.
And these symptoms are immunological in nature, likely.
Exactly.
Anybody else have any comments on this monoclonal antibodies? So this is the therapeutic monoclonal antibodies and whether they would help somebody with long COVID.
I guess I should just add and clarify that since monoclonal antibodies target the virus, if you're not having an active infection, they wouldn't do anything.
Got it. All right. Great. Okay, so they see the fast one was last. Perfect. We're going to wrap up now. And I want to thank everybody for their questions that they posted on YouTube. Again, if you have any other questions about this topic, we're going to address this topic again. Post your questions below. Any ideas for other topics we should do, put them below. Our plan is to do an episode on vaccines next. And we're working on getting guests for that one, which will be probably in about 2 weeks. With that, we'll let Fran and Sarah wrap up and the episode, and we'll start with Fran.
Yeah, thanks again for letting me be a part of this. I think the message that I would just leave with is that please wear a mask, please socially distance, don't travel over the holidays. Again, this is not just about whether you die or whether you survive, because again, there's up to potentially 30% of people who get infected who will have long-term effects from this virus. So be careful. And it's Christmas and it's a long winter, but hang in there because we need to stay safe.
Yeah, Fran, I'm with you on that one. I think so. The virus is so new. And so obviously it's like either you get it or you don't. And that's how people looked at it in the beginning. And now that you guys have gotten so much more data, even though there's still so much that you don't know, like Fran and I can attest to, like, this is not a life worth, like, for me, it's like I'm 40 years old. And I think that's where I talk about the emotional depression coming in, because like I hear that you have to, slowly get back into activities and stuff. But if this has to be my life for the rest of my life, it's a big issue. So yes, absolutely wear masks. It is the holidays. This is my favorite time of year. So I just encourage people to get creative and use your Zoom, dress up, have wine together, whatever. But you guys know it's really the only way that we can keep from spreading this. And I appreciate you guys letting me be a part of this, because I've learned more just in this past month working with you guys than I have in the past 8 or 9 months that I've, been a long hauler.
So we appreciate so much that you came on here with us. You didn't really know what this was going to be about. You were worried that we were going to be talking sciencey stuff. And I think you really helped us a lot in keeping it from getting too nerdy, I guess.
Hey, I will nerd out with you guys any day.
Well, thanks again. And thank you again to our panel. Warren, thank you so much. And Angie and Brenna is part of the group that puts this all together. And thank you, Brenna, for all the hard work and your excellent presentation today and last episode as well. If anybody's wants to check out the last episode, of course, it's easy to find on the channel. And stay safe, stay healthy, and happy holidays.